Well, good morning, everyone. Thanks for coming. My name is Greg Archel. I'm the Department Administrator at The Ohio State University, and I'm also the co-chair of the AAAEM Benchmark Committee. I'll be presenting today with Alyssa Tyransky. Alyssa is the data analyst also at Ohio State, but she also serves as the data manager for the AAAEM Benchmark Committee. So that being said, as a disclosure, we don't know if we had to disclose this or not, but she is paid by SAEM to be the data manager for the benchmark committee. So to start with, we do a lot of benchmarking throughout the industry, and when presented with data, a lot of times we hear our patients are sicker, our patients are different, our patients need more, whatever, right? So when you go to C-suite and you tell them these things, they're like, well, how do you know that? How do you prove that type of thing, right? So that's where benchmarking comes into play. So for years, AAAEM has produced benchmarking. Those of you that were at the last session kind of saw our quick synopsis of our data for last year. So we've done this since, I think, 2008, and we have been evolving. As we said, we went from spreadsheets to now we have a web-based product. So what we've been collecting over the years, obviously, is operational data, department definition data, so the mothership, what it looks like, and then kind of been using that to develop a cohort. So again, data we collect is annualized data, so trying to develop a cohort on that is the best we could do. So we have realized, as we have talked, that our data is not patient-level data. So again, when you're trying to say your patients are different, we don't have anything to help you with that. So we came up with the decision to try to determine how are our patients different. So those of you that have heard our talks in the past, Jim Schuland has done a lot of our talks. Jim was and still is co-chair of the benchmark committee with me. He formed the benchmark committee years ago and has run it. Jim has retired from Johns Hopkins, so that is why he's not here today. But he came up with this idea. He kept talking about we need an acuity index for emergency medicine. Right? We have the case mix index for admitted patients, but we need one for all of our patients. He's been talking about it for years. So about 5 years ago, we finally decided, well, let's try to do this. How can we do this? So we were trying to do this based upon the data we had, so we'll kind of walk through that with you. So the first thing was trying to understand, well, what is the definition? We were focusing on acuity when we first started to talk, and then we realized we probably need to move our discussion more to complexity versus acuity. And the big factor, obviously, is time that we're looking at. So again, trying to develop the right cohort. So when we first started, we had our operational data. So as we said, you make your cohort and you say, oh, let's find somebody who has 50,000 visits to 60,000, we'll compare ourselves. Or, are you teaching hospital versus community? So we were kind of using, again, operational things and still realizing we're missing something. So then we came up with, all right, we need to try to get patient-level data. So we can look at patient history, presenting complaints, these type of things. So when we started looking at the patient-level data, it kind of formed into these 4 categories: social needs, multiple chronic conditions and age of the patient, mental health issues, and then some specific diagnoses, which we'll get into here in a little bit. So what we wanted to end up coming up with was a way to describe the patient population at your individual institutions, and a way to consider multiple patient variables for each individual patient. So what we ended up wanting to get to was have a way to compare ourselves to get a good cohort. So when you really look at your data, you are comparing to a like institution, not just based off of an operational characteristic, but based off your patient population. And also the way to compare yourself to yourself throughout the years to see, is your patient population shifting in any way? So again, when we first started talking, we were talking about acuity, and we realized, well, acuity really is a speed thing, right? How sick is this patient when they arrive for this visit? How quick do we need to get them treated? Versus complexity, which is this patient comes in and they have all of these issues, which also gets into a speed thing, right? How quick you can get them out. But those multiple things are the reason that patient needs more resources than other patients. So again, what we did in the past, we tried to use our operational metrics. We looked at CMI for admitted patients, and then we got into this complexity index development. So when we did the inpatient case mix index, when we looked at that, we it came out, and obviously it was a no-brainer, right? Primary academics had a higher case mix index than the community hospitals. But again, that's a subset of the population, so only our admitted patients. So then again, someone asked a question in the last session about EDBA. We decided to try and use our operational data, and Jim kind of worked with ADBA, and they said, yeah, these are the 5 metrics they also kind of use to try and look at complexity of the patient population. So we used these 5: hospitalization rate, high acuity pro-fees, level 4s and 5s, ESI acuity 1 and 2, so again, high level ESI levels, EMS arrival percentage of their total patients, then your EMS admissions. So we kind of use that to say, okay, let's see, can we build something just based off the operational data? And what we came up with, again, this shows, it's kind of a busy graph, but it shows all the different years and the different colors are each different year. So if you look at what this shows the same thing as the case mix index, that obviously the primary academic centers are the highest, followed by the academic affiliates, and then down the road. So the data was very consistent, but again, this is operational data. And if you look at it by individual institutions, if you want to see if your institution fell out, that's kind of where they ranked based off of last year's data. So this is where we were. Again, based off operational data that we had, we knew we had some limitations, and we really wanted to get down to the patient level. So what we did was reached out to Vizient, because most of us are Vizient members, and they have patient-level data, and asked if they were interested in trying to develop something like this. And they jumped right in with us. And with that being said, since we're going to talk about data, I'm going to turn it over to Alyssa.
Hi, everyone. So like Greg said, a task force was created both with administrators and clinicians, and we worked with Vizient. Like a big part, Greg said, was many people in this room are members of Vizient, whether you guys know it or not. So we wanted to work with them, especially because there was one less barrier as far as like data safety was concerned. So we collaborated with them and their CDB. And we worked with Heather and Jay specifically from the Vizient team, and together we created a list of patient variables that we wanted to look at and see if it fit into this theoretical model that we once dreamed of. So overall, we were trying to establish or test the hypothesis of an emergency department that sees patients with more clinical needs and patients with more social needs will have longer throughput times. So when we initially created the model, it was just 4 hospitals. And like I said, we looked at 280 patient variables ranging from why they came there, what they were diagnosed with, all the timestamps you can think of, and many, many other things. We got daily information for 2 years, and the initial model ran really well. It was very promising. They told us things like on this day in the ED, things like age and comorbidities matter, current diagnoses matter, and we were especially hopeful because the clinicians on our team said that anecdotally this all makes sense. So since the first model was so wonderful, we were lucky enough to expand it to 10 institutions, which ranged 27 different hospitals. And if you can see in the breakdown, there are 4 different hospital types. So we kind of are getting into the same cohorts that Greg was talking about of like academic medical centers, large community hospitals, things like that. So we were able to see, is the data aligning the way we've seen in the past? And luckily, the answer is yes. Our R-square valued for the model is 0.71. And for those of you who are not statistically, or not a stats person, that is very good, especially when you think in the context of our ED, where if 71% of the time we can kind of predict what's going to happen, that is fantastic. Some of the things that stood out in the model of significance are if you see more patients, say on a Monday afternoon, it's going to take more time to see all of them, regardless of how sick or not sick they are. Patients with mental health, like chronic alcohol and psychosis, are going to add a lot more time. Older adults with many comorbidities will also add a lot of time. Oncology patients, and then to the social need piece of patients that are in what we call PCP deserts. So this is basically access to care, and we are their PCP. And also I want to point out that we're focusing on increase of length of stay, but we did find variables that decrease length of stay as well. So again, if you are a data nerd like me, this picture looks wonderful because it's a nice linear line of what we predict and what we observe kind of align really well. Each color is a different hospital, and each dot represents a day in that hospital. And hopefully this graph looks slightly familiar from one that Greg showed earlier of our academic medical centers are gonna have more complex patients. Their length of stay is gonna go up higher compared to other hospital types, and then followed by the large community, small community, and the very small. So again, this is aligning with other ways that we have seen, and we love to see that the data is making sense at every level. And I also want to point out that the outliers at each hospital type is specifically high social needs patients. So this graph right here, in case you can't see, orange is observed and blue is expected. Throughout the 2 years of our model, the two lines are pretty close, overlapping a lot of the times, further showing how strong our model is. And then this graph is individual hospitals on an individual day, whenever you can think of. So the cool thing about this graph in particular is our model predicts when your bad days are gonna be bad and your good days are gonna be good. So this was another validation point for us of like, wow, this is really telling a good story. So yeah, in conclusion, the more patients, the mental health, specifically of chronic alcohol and psychosis, and then older adults with many comorbidities and oncology and high social needs are going to impact our emergency departments. And our emergency departments that care for more clinical and social needs can expect longer throughput times than those who care for fewer clinical and social needs. And knowing this is super important because it has bigger impacts on things like our staffing models and how much space we need, what type of space we need to care for our patients. Thank you for your time, and if you have more questions outside of the question Q&A we're about to have, please come see our booth in the exhibit hall. That is a great question, and to answer it, our goal is to keep building our cohort to include things like safety net hospitals or more of them. Some of the people in the hospital, in our cohort are safety net hospitals, but we haven't called that out yet. We're gonna tie in more of those types of operational data points in further models, so it's like a yes and a no answer.
Yeah. Yeah, like Alyssa mentioned, we started with four institutions and moved to 10 or 11, whatever.
Yeah.
Anyway, so now we're kind of opening up to try to get as many people in as we can, because again, most of us are Vizient members, so it's just a matter of getting the approval to, yeah, go ahead and pull our data.
Is this in, do you have this built in Vizient, or is this in your current program?
This is built in Vizient, correct?
Yeah, we're in partnership with Vizient.
So is it accessible at CDU now?
It's not accessible yet. We're still in developmental stages right now.
You know?
Yeah, we will. Again, we want to get more institutions in, again, to validate, it looks good, but the more we get in, the stronger the model is going to be, obviously.
When you looked at comorbidities, 4 or more, is there a list of ones that matter compared to, like, you can see people's problem lists have a million things sometimes on it?
Go back to that.
Yeah, I think, isn't that in there, the one slide? You went through it pretty quick. We do have that. I don't know if we have put it in this presentation.
I was like, I don't think we have it in the slide deck, the specific one.
Yeah, well, I've seen the slide.
Yeah.
We cut this down. There you go. What's
Yeah.
that? Yeah, we have it.
Mhm.
There ones that stick out. These were the most important that were there as they're listed on that slide there. Others have some impact. And
I'd like to thank Dr. Volturo, and there's some other physicians on the task force that really helped validate or does this make sense. So one thing I want to mention is, we're talking about trying to build a cohort. So obviously, that's kind of the idea of this, is to be able to tell you these institutions have very similar patient populations as you, right? Versus just saying, hey, they have the same amount of visits. This is kind of trying to help you build a better cohort, and then you can work with that cohort.
I'm sure many of us are very interested to learn, already know that we're with Vizient. And my question for you is to get accurate benchmarking. Are there any things that you all learned during this process, like to capture, like what my patients who have the 4 comorbidities, like are there things that you learned where you weren't getting credit for certain things to enter into a cohort to make sure that what you get out of it is the right answer, like gaps?
That would probably be a great question if we had our Vizient people here, because she was the one that dug into the data. She was at our retreat in March and presented and can answer those type of questions. She really ripped this data up. So sorry I can't. I'm sure there probably is, but I just don't know.
Yes, sir.
I can talk now.
Okay.
As these models develop down the road, I think it'd be interesting to see if we have the models of the EDs that are going to have more complex patients and worse throughput time, with the academic sort of benchmarks that you're also having for productivity, to sort of have that combined so that we know, like, the EDs that are having worse staffing, higher throughputs, more complex patients affects their productivity, so that we can go to the institution, be like, this is why we're not producing as much as hospital B. We need more support in our department because the clinical care is affecting our academic work.
Yep, that's exactly the two things we're working on right now is get more institutions. And then the second thing is try to tie this with our operational data we already have. Okay, thank you very much.
Thank
Visit the
you.
booth. We could show you all of our data. We have 384 operational data points.